I'm going to be covering AKI and continuous renal replacement therapy today. There's a brief thing of what we're going to cover. Just move that out of the way. Minimize that. So we're going to look at definitions, outcomes, what could IGO say, and then talk about the basic principles of renal replacement therapy, dosing, and a little bit of prognosis. So starting with AKI, there's an old definition from the Rifle criteria 2004, and then the most recent up-to-date definition is from KDIGO, which is from 2012. And the Rifle criteria, which is fairly easy to follow if you're looking at the eGFR, because it goes up in increments of 25%, but it looks at risk, which would be sort of an AKI1, injury AKI2, and failure AKI3, and moves down. So you're looking at the serum creatinine and your eGFR, which are all quite easy numbers to look at, and then your urine output as well, say 0.5 ml per kg per hour, 6 hours, 12 hours, and then 24 hours or more. So, right, first Mentimeter. Does anyone know what the KDIGO definition for AKI is? So it's all anonymous, so just guess away. Give another 30 seconds. Hopefully someone's going to submit an answer.
So I'm logging in.
Ah, lovely. Okay. So, so far, all looking at creatinine increases. Okay, I'm going to put everyone else out of their misery. Oh, we've got another one, 12 hours, oliguric. So there is 3 things to look at. There's an increase of creatinine to 26.5 or greater. There's an increase of creatinine to 1.5 times the baseline, or looking at the urine output, which is less than 0.5 ml per kg. It's around the wrong way, for 6 hours per hour. And then could I go on to say what the definition is for AKI 1, 2, and 3? And again, it's looking at your creatinine and your urine output. So these are really hard numbers to remember. I think if you look at the American numbers, because it's different units, they're easier, straightforward numbers to remember. So I tried to come up with a way to remember it, and I couldn't. So if anyone does come up with a better way to remember it before my exam, I would love to hear it. But if you look at it on baseline rather than numbers, 1.5 to 1.9 times, or 2 to 2.9, or more than 3 times your baseline, is probably the most straightforward. And then you've got your random but not random if you convert it to the American units, 26.5 and greater than 353.6 for creatinine. And then they've thrown in one for paediatric patients as well. So if they've got a decrease of their eGFR to less than 35. Urine output's a little bit easier to remember, less than 0.5 ml per kg per hour for 6 to 12 hours, so for greater than 6 hours, and then for greater than 12 hours, and then less than 0.3 mils per kg per hour, or anuric for greater than 12 hours. Limitations to KDIGO, so creatinine is unreliable. You know, if patients got poor muscle mass, it's not going to be very helpful. It doesn't help, it doesn't look at any of the underlying etiology. You can't use it in pregnancy. And it doesn't take into account things like physiological responses to urine output, like hypovolemia, which might not be at the level that it's damaged renal function yet. And it doesn't differentiate between patients that have got a normal baseline compared to patients that have got CKD. So it's not without problems. And then just a little bit about outcomes that I thought was useful to show why it's important to take notice of patients with AKI in ICU. So absolute excess 90-day mortality, 8.6%. Population attributable risk is almost 20%. And then out of the patients that survive ICU with normal renal function before, about 13.8% of them go on to need long-term renal replacement therapy for AKI. So it's quite, I thought it was quite high numbers. Right, next Mentimeter. What nephrotoxics do we prescribe in ICU? There's loads more than 5. Oh, you can only do one response. Okay, fair enough. Sorry, I'm still working out how to use Mentimeter. Well, there's at least 7 people on the windows watching, but fair enough. 8's lovely. Thank you. Okay, so we've got metformin, opioids, fluids, NSAIDs, gentamicin, antibiotics, diuretics, furosemide. So many, I didn't write them all down because it would just take over the screen. But what I have got is antifungals, antibiotics, antivirals, mannitol, and sodium chloride, and large amounts of sodium chloride, which can cause vasoconstriction. Hypernatremia and hyperchloremia can cause vasoconstriction, and that's the way that they can be nephrotoxic. So don't just fill your patients up with loads of saline if their urine output drops. Criteria for referral. So when do we need to call nephrology or renal team? If we don't know the cause of the AKI, so we've got no idea what the cause is. If the diagnosis requires any specialist treatment, so suggested vasculitis, glomerulonephritis, any renal transplant patients, the renal team really want to know about that. If they're going to continue to need renal replacement therapy after discharge from the ICU, then obviously the renal team will need to know about that. And then in terms of criteria for referring to urology, pyelonephrosis, if they've got an obstructed solitary kidney, so if the other one's been removed or they're born with one. If they've got bilateral renal tract obstruction and a urological obstruction that's supposed to read leading to severe AKI. So I guess most obstructions, if the bladder will be relieved with a catheter, but might be higher up the tract. Right, Mentimeter. Can we use IV contrast in AKI? Yeah, sorry. It probably does depend who you talk to, but this is in the head of Hannah because I've written the presentation. So. Okay, so nobody wants to say don't give. So there's no robust evidence to support an association between patients with AKI and affecting mortality. Most critically unwell patients should receive IV contrast when it's needed. If they've got really severe AKI, you might want to consider renal replacement therapy in these patients. But it's all circumstantial. It's all we know it's nephrotoxic, but actually most patients are absolutely fine getting IV contrast, so it's not a reason not to give it. What are the indications for renal replacement therapy then? We've got acidosis, refractory hyperkalemia, it's moving, uremic encephalopathy, fluid overload, unresponsive acidosis, severe metabolic acidosis. So I've broken it down with the mnemonic AEIOU. So if they've got acidosis, if there's electrolyte problems, so we talk about refractory hyperkalemia, intoxication for drug overdose and things that can be filtered out, they're fluid overloaded, if they're uremic, and then we've started using it as well for removal of inflammatory mediators related to sepsis, which I've written down as controversial, because although we're using it for that, there's differing evidence, so it's described as controversial. Should we be starting renal replacement therapy early? Probably also, depending on who you speak to, but Bain. If you go on Mentimeter, there's a code as well. If you just Google Mentimeter. Okay, so you've got 4 no's, 6 no's. So quite resounding no's there. So no mortality benefit has been shown so far by commencing renal replacement therapy early. But we do know that there's risks of putting patients on renal replacement therapy to do with line insertion and anticoagulation. And there's potentially a greater risk of continued dependence on renal replacement therapy following their ICU discharge, that's been found in some of the studies that's looked at timing for starting renal replacement therapy. Is there a role for sodium bicarbonate? I know I'm sitting with 2 of the people that are 2 of the people that are involved in the trial. Okay. So the evidence that I've got says that that sodium bicarb has not been shown to improve outcomes like mortality or length of stay. However, the amount and duration of renal replacement therapy might be reduced, so that could minimise associated complications and morbidity. So there, yes, could be some benefit, but not so far on mortality. And you can speak to some of the others about the trial that's ongoing at the moment if you're interested. Right, so renal recovery. So when is the patient no longer an AKI? Kaligo says that it's the absence of the diagnostic criteria for AKI, which was your creatinine at 1.5 times baseline or 26.3, was it? 23. Thank you, 26.5. I can remember it. Or urine output of less than 0.5 ml per kg per hour for at least 6 hours. Other times when it might be stopped, so if we're looking at limiting some of the treatment the patients are on, if they've got their renal functions back to normal and they're passing urine, sometimes we stop it if the circuit gets clotted, and we say, well, we'll have a break and see what happens. And some studies suggest that you can look at creatinine clearance as well to help decide when to stop our renal replacement therapy. So talking about renal replacement therapy now, and I've tried to structure it in the way that I wanted to learn it, so I hope it's not too, doesn't jump about too much for you all. So hemofiltration, this is a hydrostatic pressure gradient across the membrane, and what you get is, if you look here, you've got blood coming into the filter. We put dialysate in, and then you get effluent fluid out, and then it's returned to the patient. And you can decide how much fluid you're putting in and out. And in my I'll tell you on the next page actually why, how I sort of factor it in my head. So hemofiltration is about increased pressure, so it's a pressure gradient from the high to low. And then hemodialysis is you've got your pre-dilution fluid that you put in, effluent comes out, and you get your post-dilution fluid that comes out before you return the blood back to the patient. And it's really this countercurrent across gradients. So the way that I've got the pictures wrong, that's why I was getting it confused. This is a hemofiltration picture, and this is a hemodialysis picture. So I'll try and explain it without looking at the words. So don't look at the don't look at the words because they're the wrong way around. So for hemofiltration, you've got this high pressure moving towards dragging things out through low pressure. And this is for use for bigger molecules compared to your hemodialysis, which is for smaller molecules. So some of your drug toxins like lithium will be smaller molecules that come out of the dialysis. And the way that I think of it is smaller ones will fit through the gaps because they're small, and the bigger ones need that high pressure to force them out. And that's my head. So I've got them side by side so that you can see again. So for the dialysis, once again, you've got smaller molecules being filtered out, and your hemofiltration, you've got your larger molecules that are being forced out through the higher pressure. And it's this one where you've got your pre-dilution fluid that goes in and your post-dilution fluid that comes out, where you can play about with the numbers and take fluid off or increase patient's fluid. I hope that makes sense. We're going to go over it a little bit more in other ways. So just to make sure you're all listening, what is the difference between hemofiltration and hemodialysis? Which one uses convection, where water and solutes are filtered by applying pressure? Okay. Yeah. Yes, so 6 of you got that right. So I hopefully either didn't do that bad a job of explaining it, or you already knew it before you came on. Okay, next Mentimeter. What are the risks of renal replacement therapy? So I'm seeing infection as some of the biggest writing. So I'll start reading some of those out. Coagulopathy, delirium, thrombus, reliance on dialysis, fluid shifts, allergies, coagulopathy, cerebral edema, delirium. So cannula related, so putting it in with bleeding and infection. Inflammatory response, sometimes patients get that and they end up with prolonged AKI. Some of the fluid shifts can cause hypovolemia or instability. You've got to think about the drugs that you're giving because there could be altered metabolism. There's the anticoagulation risk depending on what you're using to anticoagulate. Loss of circulating blood volume and failure to meet your renal replacement therapy. So, and then there's the increased nursing workload as well. So these are level 3 patients. And then CVVHDF, which is what most of our patients are on, is the hybrid method. So it's both hemodialysis and hemofiltration. And it takes advantage of the ability to dialyze the small molecules and to filtrate out with the pressure the medium and larger molecules. So when you're deciding whether a patient needs renal replacement therapy, there's a few things to think about. So first question, should it be continuous or intermittent? On ICU, we give continuous dialysis, renal replacement therapy, but the renal team, for example, could give intermittent. So have a think about the stability of the patient, what resources you've got available to you. So sometimes the renal department might be in a different hospital, it might be out of hours, and what vascular access the patient's got or needs to have. We use continuous on ICU because it gives better hemodynamic stability, because you've got less huge amounts of fluid shifts, because it's spaced out over a longer time rather than a couple of hours. You can manipulate the fluid balance better. It can be useful for that inflammatory mediator clearance in sepsis, and theoretically helps to preserve the cerebral perfusion with the without the significant fluid shifts. SLED, you might also see SLED being used on some ICUs. So it stands for slow low efficiency dialysis. And it's a form of continuous renal replacement therapy, but it's given over 6 to 12 hours. So it's a sort of hybrid between the two. It's great because if patients are on it overnight, then they can be up and not attached to the filter during the day, and can move around and do things. But there's been no demonstrable survival benefits from using SLED. So how do you prescribe renal replacement therapy? So I'm just trying. Hopefully no one's fallen asleep. Try and concentrate because there'll be questions coming up shortly. So most ICUs have got sheets that you just sign the boxes that the nurses point at, and you don't necessarily think about what you're signing or prescribing. So I wanted to include this because I think it's important to know when you've got different circumstances to know what you're prescribing and why you're prescribing it. So I hope it makes sense. So the dose, so you can look at the effluent rate, which is the fluid that's coming out, that determines the effluent rate determines the amount of solute and electrolyte exchange during renal replacement therapy. So if you want to get solutes out faster, if you want to bring down the potassium faster, you would increase the effluent rates. And KDIGO suggests that we should be aiming for, like a normal rate would be 25 to 30 mils per kg per hour, and that would end up with a slightly lower rate of 20 to 25 to account for things like treatment interruptions and things like that. So you've got to have a think about drug dosing as well when you've got a patient on renal replacement therapy. And I think that's why it's so useful to have amazing ICU pharmacists. So if you've got low protein, if the drug's got low protein binding, it's more readily removed from renal replacement therapy. And if it's got a higher volume of distribution, it's usually got a lower clearance rate by renal replacement therapy. And just a couple of examples, I'll move out of the way. Just a couple of examples that I put down are things like vancomycin, antifungals and beta-lactams, where you need to look at changing your dosing when a patient's on renal replacement therapy. And if you're not sure, then just make sure you check in with your pharmacist or ask somebody or look it up. So next question, Mentimeter. What does KDIGO say we should be using as site preference for VASCAF? And I want you to rank them in order. Give it a few more seconds to see if anyone else wants to give an answer. So it looks like your right internal jugular vein is the preference, first preference, and then you guys have selected left, and then non-dominant hand, subclavian vein, dominant hand, subclavian vein, and femoral vein. I think I'll move on and we can see what the answers are. So not quite right. Yeah. So we should be going right side internal jugular first. Everyone got that right? Well done. Well, I don't know that everyone got it right. The majority of you got it right. And then second line, they recommend either femoral vein. And then third line would be your left internal jugular vein. Fourth line is your dominant hand. And then fifth line is your non-dominant hand. Because I couldn't work it out whether it was, or maybe if a patient's writing with a hand, why would that affect it? But your non-dominant hand is most likely to be used for an AV fistula. So patients are going to go on to need long-term renal replacement therapy and dialysis by the renal team. That's why they want you to avoid the non-dominant hand supraclavicular vein. Subclavian, thank you. I did know that. I did look it up on another site, so that's what Godigo recommends. The other site recommended that you use the right side subclavian vein over the left, because the left ends up having a bend in it that can make it a little bit more difficult to thread. Anticoagulation options. So you need to think about anticoagulation for patients on renal replacement therapy. Citrate is first line, but some hospitals don't use it yet. heparin will be second line, and then there's other options as well. Citrate, you can think of it as a regional anticoagulation. So it's not given to the patient, it's given, it's added to the bloodstream before it goes into the filter once it's left the patient. And it's predominantly metabolized in the liver and muscles, and it also produces bicarbonate, so it can cause a mild metabolic alkalosis. So this is just a diagram to show what I've just said. So blood goes in towards the machine, citrate's added, and then it forms these citrate calcium complexes, which some of them come out in the dialysates, and they come out in the effluent, and then some's returned to the patient where it's metabolized in the liver. So you need to monitor patients when you're using citrate to make sure that they're not becoming, they're not going into having citrate toxicity. So it's recommended that you measure their ionized calcium. So you'll see patients are getting regular gases, they're already getting from ICU. But you're looking to make sure that they're getting enough calcium replacement to replace what's been complexed in with the citrates, and that you're avoiding citrate accumulation. So pros and cons of using citrate: it avoids any systemic anticoagulation to the patient. So if you've got a patient that's bleeding risk, it's better for them. It's safe to use in heparin-induced thrombocytopenia. It prolongs the circuit lifespan. So we talk about how the circuits have been clotted off, so you've had to stop it early. So you're less likely to get that with citrate. And there's clear safety protocols for it. The disadvantages would be the risk of citrate overload and, more seriously, toxicity. And you can get electrolyte imbalances that you need to keep on top of. So citrate overload versus citrate toxicity. So I guess the main things to take away, is a lot of writing on these slides, is that you'll get a metabolic alkalosis with citrate overload. Citrate overload isn't dangerous, and it's easily treatable. Whereas citrate toxicity, you get a HAGMA, so high anion gap metabolic acidosis. So it's just interpreting the blood gases appropriately. These patients will need their citrate stopping, and you might need to give some calcium substitutions. You might get more dramatic electrolyte changes. So it's just making sure you keep on top of the blood gases on a patient that's on citrate filters. So just last couple of slides now. Prescribing continuous renal replacement therapy. So as a quick recap, hemofiltration is best for fluid removal and the larger molecule clearance, and hemodialysis is best for small solutes like your toxins, and then we often use the combined one. Flow rates, your standard flow rates for the effluent rate is 20 to 25, and then you could put that up to 30 to 40 if you want a higher toxin clearance. And for your dialysate rates, your standard is 1.5 to 2.5 litres an hour, and you can increase that if you want a higher clearance of toxins. So I've got this right. So this is your hemodialysis, right picture. Dialysate comes in, effluent fluid comes out. And then looking at the filtration, you can put in your pre-dilution fluid and your post-dilution fluid comes out. So you look at, goes into the patient, and you can decide what percentages that you can give. So you can give 50% of the fluid before, 50% afterwards, or you can adjust it. And if you increase the amount of pre-dilution fluid, your filter is going to last longer. It's less likely to clot and have to come off, but it reduces the clearance. Whereas if you do increase the post-dilution fluid, you can really maximise the solutes that you're removing, but risk the filter clotting. And then your ultrafiltration rate is your fluid removal that you're going to use if you've got a patient who's a fluid overloaded, we take the fluid off. So last few questions and then we're going to finish. What would you do if your acidemia does not improve despite being on renal replacement therapy? So we've got looking for the underlying cause, giving some sodium bicarb, asking the renal team to review the patient, try changing the filter, using the acidosis protocol, palliation, check for other causes. So first of all, exclude some really common patient causes. Is the patient profoundly septic, and that's why they've got this prolonged ongoing metabolic acidosis. And then have a look at the equipment, see if you can optimise what you're doing. So you can increase the blood flow, you can reduce the pre-dilution. So we said that increased pre-dilution helps the filter to work better, but takes less of the solute out. So you could increase the pre-dilution. You could have a look at the vascular access. Is there a problem with the vas cath that you put in? You could try increasing the effluent dose, and then minimise any interruptions, which hopefully the patient won't be getting. But just checking things like that. So now I'm going to ask you what you would prescribe for. So I'm just looking at you because you're in front of me. I'm going to ask, what would you prescribe for the following conditions? So we're going to look at, we're not looking at the last one, we're just looking at lithium overdose, tumor lysis syndrome, sepsis, septic shock, and rhabdomyolysis. So if you've got a patient that you've brought up from ED and they've taken a lithium overdose, what are the things that you need to think about when you're putting them on the filter for your prescribing, other than just signing the boxes that the nurses point out? So we've got to give hemodialysis instead of hemofiltration. Give them the antidote. What is the antidote for lithium? No, she said dialysis. Okay. So we've got, so I think most people have written, so we've got HDF, hemofiltration, CVVH, that doesn't tell you whether it's hemofiltration or dialysis. No, it isn't permitted. No sodium chloride and an even balance. So you could give a higher effluent rate and dialysate flow to try and improve toxin clearance. You want an even balance of your pre-dilution and post-dilution fluid, usually in a neutral fluid balance as well. And you should consider intermittent hemodialysis if the patient's stable, or if it's available, if you're able to do that, because lithium is really toxic and it will come out faster with intermittent hemodialysis over renal replacement therapy, continuous renal replacement therapy. Right, what are the things we need to think about bitumen lysis syndrome? A thumbs up from somebody, thank you. Okay, so we've got probably one for hemodialysis, somebody else for hemofiltration, somebody for both. Slow effluent rates, fluids, allopurinol, raspuricase, red blood cells, watch their electrolytes, even balance, hemodialysis. So I've got a high effluent rate and dialysate flow to try to improve your phosphate clearance. You can increase the post-dilution replacement fluid to maximise clearance as well. And then monitor calcium really closely because these patients are at risk of calcium phosphate precipitation. What about if your patient is in septic shock? Maybe antibiotics. We've got filtration rather than dialysis, low and slow. Thinking about things like fluids, IV, antibiotics, noradrenaline, avoiding fluid shifts. Might need high rate Bori. Even balance. Hemodialysis. Right, let's have a look. Got some more. SLED, if you've got it. So standard flows, so you don't need to increase anything to try and remove it quickly. Fluid removers needed if you've got a patient who is overloaded, and then just be very mindful of anticoagulation if they develop DIC. And you can take all anticoagulation off if needed. Right, last one, rhabdomyolysis. What do we need to think about? Got hemofiltration. Watch out for their potassium. Don't take off fluid bolus. High dialysate and effluent rates. Potassium. A few people have said potassium. So the aim of renal replacement therapy in rhabdomyolysis is for myoglobin clearance. You want to have a high effluent rate and higher post-dilution fluids, normal dialysate flow. Don't take off fluids. I think a lot of people said that. These patients need really aggressive fluid resuscitation. And if their creatine kinase is over 50,000, consider whether intermittent hemodialysis with the renal team would be more appropriate at clearing that myoglobin faster. Right, last slide, renal prognosis for those on renal replacement therapy. So about 40% of patients survive to hospital discharge. And in those that survive to hospital discharge 1 year after, 48% have a complete renal recovery, 33% have an incomplete recovery, and 19% are dialysis dependent, which increases further at the 3-year mark. So it's very important how we manage it. That's it. Thank you for listening. Thanks for participating. Hi, Jenny.
Oh, yeah, this was on an unrelated matter, but if I can just put a couple of points at the end before everybody runs away, that'd be good. I think as a consultant group, just exercise some caution with femoral lines, please. I know that's what KDIGO say, but we get a lot of site infections, unfortunately. Boo. Thank you. Had an excellent talk. Well done.
Thank you.